Good morning, everybody. Our lecture oral mucosa. We will start with the infectious diseases. We should know how oral tissue or oral mucosa appear white and how it is appear red. I mean, what is the causes of white appearance and red appearance of the oral mucosa? A white appearance of oral mucosa may be caused by a variety of factors. First of all, increase in production of keratin, which is hyperkeratosis, abnormal thickening in the stratum spinosum, which is acanthosis. Third, intra and or extra accumulation of fluid result in whitening of oral epithelium. And finally, microbes, which is mostly fungal infection, which is oral. This is how the hyperkeratosis appear in the oral cavity in the This is the accumulation of fluid. And here the fungal mycelium, which is the oral candidiasis. Now, why oral mucosa appear red? Development of red lesion or red color in the oral mucosa may be related to either atrophy of epithelium, which means reduction in the number of epithelial cells, or increased vascularization. This is how atrophic and this is how ulcer appear. As you know, the ulcer is the discontinuity of epithelium. Now, we will start with the infectious diseases and we will start with the oral candidiasis. Oral candidiasis is the most prevalent opportunistic infection affecting the oral mucosa, with the majority of cases caused by Candida albicans. The pathogenicity of oral candidiasis is not fully understood. However, there is a number of predisposing factors converting the Candida albicans, which is a normal commensal flora saprophytic stage, into a pathogenic or parasitic stage. Candida albicans is a weak pathogen, but it is an opportunistic pathogen in the same time, affecting very young, very old, very sick people. Most candidal infection affecting mucosal lining, but in systemic affection also. Oral candidiasis also divided into primary and secondary. The primary infection restricted to the oral and perioral sites of the tissues, while the secondary infected oral candidiasis associated with the systemic mucocutaneous manifestation. Etiology and pathogenesis of the oral candidiasis, as we said, oral candidiasis mostly albicans, tropicalis, glabrata, all of these forming 80% of species isolated from the human candidal infection. But as we said, Candida albicans is the most prevalent one. To invade the mucosal lining, the microorganism must adhere to the epithelial surface. So candidal strain with better adhesion have more virulence than candidal strain with poor adhesion ability. The yeast penetration into the epithelial tissue is facilitated by the production of an enzyme called lipase. And for the yeast to remain within the epithelium, it should have the ability to overcome the constant desquamation process by the oral epithelial tissue. As you know, it is 24 turnover. Now, what is the predisposing factor for oral candidiasis and candida-associated lesion? We have local factor and we have general factor. Local factor including denture wear, smoking, atopic constituency, inhalation steroid, topical steroid, hyperkeratosis, imbalance of oral microflora, quality and the quantity of the salivary flow. The general factors including immunosuppressive diseases, impaired health status, immunosuppressive medication, chemo. A primary oral candidiasis subdivided into acute, chronic, and nodular. Acute, pseudomembranous erythematous, and the chronic one also pseudomembranous erythematous plaque-like. The nodular type including candida-associated lesion, denture stomatitis, angular cheilitis, and median rhomboid glossitis. Secondary oral candidiasis including familial chronic mucocutaneous candidiasis, diffuse chronic mucocutaneous candidiasis, candidiasis endocrinopathy syndrome, familial mucocutaneous candidiasis, severe combined immunodeficiency DGeorge syndrome. Now, what is the epidemiology of the oral candidiasis? It is an oral commensal flora, large geographical variation, more common isolated from the women. It has a seasonal variation. It is mostly observed during summer months, mostly prevalent in hospitalized patients. Also, healthy individual, blood group O and non-secretory blood group antigen are risk factor for oral carriage of the Candida albicans. Also, in patients with complete denture wearer, the prevalence of denture stomatitis has been reported from clinical finding of pseudomembranous candidiasis. It is an acute form of oral candidiasis or thrush. It is primary oral candidiasis, and it is also the classic candidal infection type. Infected patient predominantly taking antibiotic, immunosuppressive medication. Erythematous candidiasis is previously known as atrophic oral candidiasis. It is not just reflect on atrophy of the epithelial tissue, but may be also explained by increased vascularization. The lesion with diffuse border help to distinguish erythematous candidiasis from the erythroplakia, which is mostly have a sharper demarcation line. The infection is predominantly seen in the palate, dorsum surface of the tongue, in patients with inhalation steroids. Also, there are other predisposing factors for this type of erythematous candidiasis, which is smoking, chronic plaque type, and nodular candidiasis, previously known as Candida leukoplakia. It is a white irremovable plaque characterized by clinical presentation of indistinguishable from the oral leukoplakia. A positive correlation between this type of candidiasis and mild moderate severe dysplasia has been found. It is mostly associated with malignant transformation, but the possible role of yeast in oral carcinogenesis is not fully understood, not clear. But it has been hypothesized that the Candida albicans has the capacity to catalyze denture stomatitis may be classified into 3 types: type 1, type 2, and type 3. Type 1 is limited to minor erythematous site caused by trauma from the denture. Type 2 affects the major part of denture covered area. In addition to the feature of type 2, type 3 has a granular mucosa. The denture acts as a vehicle that accumulates slough, epithelial tissue, microorganism, food debris, preventing the mechanical cleansing effect of the salivary flow. The microflora is a complex. Maybe in addition to albican, there is other several types of bacteria such as Streptococcus, Lactobacillus, Provatella, Actinomyces strain. It is till now it is unknown whether the denture stomatitis is completely associated with fungal infection or other bacteria may Now, the angular cheilitis. Angular cheilitis is an infected fissure of the commissure of the mouth surrounded by erythematous area. The lesion is frequently affected by Candida albicans and Staph aureus bacteria. Also, it has been found that vitamin B12 deficiency, iron deficiency, loss of vertical dimension, mostly in patients with dentures, or edentulous patient may be associated with this type of disorder. Also, dry skin in patients with angular cheilitis may promote fissuring of the commissure and invasion of microorganisms through these fissures. It has been found that 30% of patients with denture stomatitis may have angular cheilitis. But however, it is only 10% of Now, median rhomboid glossitis. Median rhomboid glossitis, clinically, it is an erythematous lesion, can be seen in the center of posterior part of the dorsum of the tongue. It is an oval in shape. The area with erythematous result from atrophy of filiform papillae, and the surface may be lobulated. The etiology is not fully clarified, but the lesion shows a mixture of fungal and bacterial infection. Biopsy from this area showed candidal hyphae in more than 85% of lesion. A smoker patient and denture wearer patient have increased risk to develop median rhomboid glossitis. Patient with inhalation steroids also subjected to median rhomboid glossitis. Sometimes there is what is called a kissing lesion occur concurrently with the median rhomboid glossitis observed in the palatal mucosa of the patient. Median rhomboid glossitis may be asymptomatic, and the management should be restricted to the removing of the cause. There is no any risk for malignant transformation in this type of lesion. So a patient come to the clinic should be reassured that this Now, oral candidiasis associated with HIV. More than 90% of patients with acquired immune deficiency syndrome having oral candidiasis during their course of infection. The most common type of oral candidiasis associated with HIV patient is the pseudomembranous erythematous candidiasis, angular cheilitis, and chronic plaque-like candidiasis. As a result of using enterovirus therapy, HAART therapy, the prevalence of candidiasis nowadays has been decreased. Now, how we can diagnose the oral candidiasis? Diagnosis and laboratory finding. The presence of Candida microorganism as a member of commensal oral flora discriminate the normal state from infection. It is difficult to discriminate normal from infection. So the detection of yeast organism in the form of hyphae, pseudo-hyphae-like structure is usually considered a sign of infection, although these structures have also been identified in normal oral mucosa. The results of discrimination may be expressed by colony forming unit per cubic millimeter, CFU millimeter square cubic millimeter. This method is available for diagnostic procedure for erythematous candidiasis, denture stomatitis, and also we can do salivary culture. From this culture, if the CFU more than 400 per mol, considering a chronic black type and nodular candidiasis, cultivation in addition to histopathological examination is important because there is a malignant transformation in this type of candidiasis. So there is clinical and histological examination to rule out epithelial dysplasia, which is first step in malignant transformation. And to identify the microorganism, pus stain should be used for the candidal hyphae. Now, what is the management of patient with oral candidiasis? Treatment using antifungal therapy. However, it is not always successful unless the clinician addresses the predisposing factor and that factor cause recurrence. So, oral factor should be removed and eradicated completely, eliminated, and associated with antifungal medication. It will be a successful therapy, removing the cause and giving the treatment. In a smoker, cessation of the habit may result in disappearance of the infection without antifungal medication. Antifungal medication belonging to pollines or azole. Pollines such as nystatin and amphotericin B, these both are a drug of choice for the treatment of primary oral candidiasis. Elimination of reduction of a predisposing factor should be always the first goal in the treatment of oral candidiasis. Also, this involves improving denture hygiene, removing the denture while sleeping, because the denture is important vehicle for the infection. It should be cleaned to disturb the maturity of the microbial environment established under the denture. Porosity of the denture is very important, and this type of denture should not be given to the patient because the holes in the porosity act as a media for the fungal to cultivate, and a patient should advise to store the denture in antimicrobial solution during the night. There are many different solutions used: alkaline peroxidase, alkaline hypochlorite, disinfectant, enzymes. All have effect against the candidal strain. Also, chlorhexidine may be also used. However, it may cause discoloration of the denture, oral tissues, and also considering type 3 denture stomatitis, the treatment may be with surgical excision that to eradicate the microorganism present in the deeper fissures of the tissue, and if this is not sufficient, antifungal medication should be considered. Topical treatment with azole, such as miconazole, is the treatment of choice for angular cheilitis infected both with Candida albicans and Staph aureus. Angular cheilitis surrounded by erythematous area. Mild steroid may be used, ointment may be used to suppress the inflammation. Also, to prevent the recurrence in those patients, moisturization cream must be applied for the systemic azole may be used for deeply seated primary candidiasis, such as in chronic hyperplastic candidiasis, denture stomatitis, and median rhomboid glossitis with a granular appearance. However, there are several disadvantages with the use of azole. They interact with warfarin, leading to increased bleeding potentially. Topical application of azole are fully or partly reabsorbed from GI tract. Development of resistance in a patient with fluconazole, in individual with HIV patient. In such cases, ketoconazole and itraconazole have been recommended as an alternative for this type of medication. The azole are also used in the treatment of secondary oral candidiasis associated with systemic. Now, what is the prognosis of oral candidiasis? A prognosis of oral candidiasis is good when the predisposing factor is reduced or eliminated. Persistent chronic type and nodular candidiasis have been suggested to be with an increased risk for the malignant transformation compared with leukoplakia not infected with candidal strains. So, prognosis is good when you remove the cause and give treatment. Prognosis is not good when you leave the cause, and prognosis not good prognosis in case of nodular and plaque. Now, we will talk about the second infectious diseases, which is the oral hairy leukoplakia. It is the second most common associated oral mucosal lesion and used as a marker of disease activity. But however, it is not pathognomic because it can be seen in other type of cases, an immunosuppressive drug patient, cancer patient with chemotherapy. However, because it is associated with low CD4 T lymphocyte, it may be considered as a marker, disease marker for those type of patient. It is strongly associated with Epstein-Barr virus and low-level CD4 T lymphocyte. Antiviral medication prevent Epstein-Barr virus is a curative for oral hairy leukoplakia. In AIDS, the prevalence may be as high as 80%. In AIDS patient, the prevalence may be as high as 80%. In children, the prevalence is lower compared with adult 2%. It is more frequently in men, but reason for this predisposition is not fully known. A correlation clinical finding, it is encountered or it is affecting the lateral surface of the tongue. It also may be observed in the dorsum and buccal mucosa. It is asymptomatic unless it is associated or super infected with candidal strain. It is very important to consider mucosal lesion whenever the lateral border of the tongue is affected by white lesion, particularly in patients with immunocompromised state. So when we see any white lesion, red lesion in the lateral surface of the tongue, we should take care for those type of patients. Diagnosis of oral hairy leukoplakia is based on a clinical characteristic, but histopathological examination to detect Epstein-Barr virus is important to confirm the diagnosis. In management, it is successfully with antiviral medication, but this is not often indicate as this disorder is not associated. Now we will discuss the pre-malignant disorder. This is an old terminology. It is now replaced by the potentially malignant disorder, which is the oral leukoplakia and erythroplakia. As a pre-malignant lesion, it involves different genetic events. Activation of oncogenes, deletion and injury to the suppressor gene, gene responsible for DNA repair, will all contribute to the defective functioning of the genome that control the cell division. Following a series of mutation, a malignant transformation may happen. Carcinogens such as tobacco may induce hyperkeratinization, which is reversible following cessation, but at some stages the mutation will lead to unreversible proliferation of the cells. A global review point out that the prevalence of oral leukoplakia 2.6%. Most oral leukoplakia in patients have been registered beyond the age of 50, and it is infrequently to be appear in a patient below the age of 30s. Leukoplakia are more common in men, but there is a slight majority for women, has been also found in some studies. Oral erythroplakia is not as common as oral leukoplakia, and the prevalence is ranging from 0.02% to 0.1%. The gender distribution is reported to be equally. According to the WHO, oral leukoplakia may be defined as a white plaque of a questionable risk, having excluded other non-disease or disorder that carry no increased risk for cancer. This disorder may be further subdivided into homogeneous leukoplakia and non-homogeneous leukoplakia. The homogeneous type characterized by a white, well-demarcated plaque with an identical reaction pattern throughout the entire lesion. The non-homogeneous type appear as a white and red lesion, speckled leukoplakia, non-homogeneous leukoplakia, or erythroleukoplakia. So it is a mixture of white and red lesions. Oral leukoplakia may be found at any site in the oral cavity. Non-smokers have a high risk of leukoplakia at the border of the tongue compared with the smoker. Floor of the mouth, lateral surface of the tongue have been considered as a risk cavity. These sites have been also found to have a higher frequency of loss of heterozygosity compared with low risk sites, which is other risk sites in the oral cavity. However, distinction between high and low risk site has been questioned, leaving the size of the lesion, the homogeneous and non-homogeneous pattern for the prognosis to be affected. So the size of the lesion, the non-homogeneous pattern, loss of heterozygosity, high risk sites for the oral cavity, all these give rise to area of suspicious area for malignant transformation. You can see here the homogeneous leukoplakia, which is a plaque-like white color, and this is the This is erythroplakia at the alveolar area. Patient Now, verrucous or verruciform leukoplakia. It is a special form of leukoplakia with a papillary projection similar to oral papilloma called verrucous or verruciform leukoplakia. Oral leukoplakia with more aggressive proliferation pattern, high recurrence rate, are designated to be a proliferative verrucous leukoplakia, PVL. This type of leukoplakia can be seen in older women, in the lower gingiva, which is the predilection site for this type of lesion. Malignant potential is very high, and verrucous carcinoma or squamous carcinoma may be present at the primary examination. Similar to what's seen in oral population. This is the proliferative verrucous leukoplakia in an 80 years old woman. You can see now, according to the WHO, oral erythroplakia defined as a red lesion in the oral mucosa, diagnosed by exclude other non-pathologies. It is asymptomatic. However, some patients experience burning sensation during food intake. There is a special form of erythroplakia reported in Indian people due to reverse smoking of chatta. Diagnosis of both leukoplakia and erythroplakia is identical. The professional diagnosis is based on the clinical observation of a white or red patch which is not explained by other definable cause such as trauma. If the trauma is suspected, such as sharp tooth restoration should be eliminated. If the healing does not occur within 2 weeks, dysplasia is a term can be found in homogeneous leukoplakia but is much more frequently in non-homogeneous leukoplakia and erythroplakia. Epithelial dysplasia is a general term as the appearance of the lesion of stratified squamous epithelia characterized by cellular atypia and loss of normal maturation. Carcinoma in situ is defined as a lesion in which a full thickness of the squamous epithelia show cellular feature of carcinoma without any stromal invasion. The dysplasia classified into mild, moderate, severe, or can be classified into high risk or low risk dysplastic lesion. Since alcohol and smoking are both well-established risk factors for the development of oral candidiasis, measures should be taken to influence the patient to discontinue such harmful habits. Cold knife surgery as well as laser surgery both are widely used to eradicate leukoplakias and erythroplakias, but this will not prevent the brain. So, squamous cell carcinoma are almost equally prevalent in patients subjected and not subjected to surgery. This may be explained by what is called genetic defect, even in a clinically normal mucosa surrounding the removal of the lesion in the area. This is supported by a concept called field cancerization. It is caused by simultaneous genetic instability of the epithelium of several extra lesional sites that may lead to squamous cell carcinoma. However, in the absence of evidence-based treatment strategies, oral leukoplakia surgery remains the treatment of choice and also for erythroplakias. Malignant transformation of oral leukoplakia from 1 to 20% over 1 to 30 years of duration. Homogeneous leukoplakia are associated with decreased risk for malignant transformation compared with non-homogeneous leukoplakia and erythroplakia. As we said, the size of the lesion is very important. So lesion not exceeding 200 cubic millimeter lesion not exceeding 200 millimeter appear to have better prognosis than larger lesion. So there is a relation between the size of the lesion and now, considering the follow-up of of a patient with oral leukoplakia and erythroplakia, there is no consensus to reach management plan for the follow-up of patients with oral leukoplakia erythroplakia. However, there is a general recommendation to re-examine the potentially malignant disorder irrespective of doing surgery or not. 3 months for every 3 months for the first year of lesion. If the lesion does not relapse or change in reaction pattern, the following interval may be extended to once every 6 months. A new biopsy should be taken if a new clinical feature emerge. Following 5 years of no relapse, self-examination may be a reasonable approach for the patient. Nowadays, there is tools helping the clinician in the identification, the high-risk area in the lesion, guiding the clinician for the right sites for the biopsy taking from the lesion. One of these tools called the Villiscope. It is an effective tool for diagnosis and follow-up of this device using blue light excitation. If it is normal area, there is what we call the fluorescent pattern associated with normal or dysplastic, changing the reaction of the color. Normal tissue, there is normal fluorescence pattern, normal epithelial cell, while abnormal loss of fluorescence associated with dysplastic changes surrounding the stroma give us different color, maybe more darker color, which give indication that this area is diseased area and this is a normal area. So it helps us in taking biopsy and follow-up of patient with or without